Hello and welcome to Local Doctors on Call. I'm Alex Redmond. Dr. John Moor is a medical doctor and orthopedic surgeon specializing in knee and shoulder arthroscopy and arthroplasty. He has completed more than 15,000 surgeries in Sarasota over the past 18 years. He's also on the teaching faculty of Florida State University College of Medicine and LECOM. Dr. Moor teaches arthroscopic procedures to orthopedic surgeons all over America and internationally. Welcome to Local Doctors on Call, Dr. Moor.
Thanks. Hi, Alex.
Well, I understand that you came here straight from the hospital after performing 8 joint replacements. You must be exhausted. How do you feel?
I feel great. Actually, it's a lot of fun to help people throughout the day, and 8 people are happier, are going to be happier at least soon because of their knees or their shoulders today because of what we did.
So what did you do? Tell us a little bit about the day.
Today we did 7 total knees and 1 total shoulder, and so we start at 7 in the morning and go until we're done, and they all went as planned.
And typically, who are your patients? Do you have just a certain age group or?
For total joint patients, typically it's an older group, but in my practice, anybody is welcome to come. I do sports medicine, which evolves into a total joint practice. And so I have everybody from pee-wee football players to 90-year-old tennis players and golfers.
So you even have little kids that hurt themselves and pro players.
Yes, indeed. In fact, they don't even have to be an athlete to have a shoulder or a knee or a hip problem.
And you teach internationally and nationally. When is your next teaching gig?
Actually, this weekend I'm going to be in Chicago at the National Learning Center, which is part of the Arthroscopy Association of North America. And we're going to be teaching a cartilage regeneration and restoration course to orthopedic surgeons from all over the country, and we'll even have several people from internationally.
Yeah, that sounds like it's way up there on the cutting edge of what's going on right now.
It's pretty neat stuff. It's pretty much cutting edge, and it's not so much what's even been published yet. It's what the experts around the country are doing.
Now, if people want to get information on when you're teaching, do you have a website that they can reach you at?
We do have a website, advancedsportsmedicine.com. However, these courses are only for orthopedic surgeons, so I do courses for the public, and those are posted on my website, but the courses that we just talked about are only for orthopedic surgeons.
All right, we want to let everyone know that Dr. Moor is answering your questions. We are live tonight, and you may call us at 361-4675. Again, that number is 361-4675, because there are so many people out there that have shoulder injuries or shoulder problems. Maybe they pulled something, maybe they fell over, they injured it. So let's talk a little bit about knee and shoulder arthroscopy and arthroplasty, and what exactly is that? Because a lot of people don't know.
Sure, those are big words, and arthroscopy references surgical procedures that are done through small incisions, literally this big, sometimes small enough you don't even need stitches when you're done. And you access the joint by placing a microscope through the skin into the joint, and through that scope you can see the entire joint, and then we take care of whatever we find at that time. It's usually under local anesthesia, does not require general anesthesia, or sometimes regional anesthesia, which means the entire limb instead of just a local area, and as opposed to arthroplasty, which is a fancy word for joint replacement or surface replacement. And that means you have to make an incision big enough to allow the components to go through, but it's mostly for arthritic or degenerative joints. So that's one that needs to be at least overnight in the hospital. Also doesn't need general anesthesia. Can be done in regional. Those are the differences.
All right, we have Stephen on the phone. Hi, Stephen. Welcome to Local Doctors on Call. What is your question for Dr. Moor?
Yes, thank you. Dr. Moore, my question is regarding, I discovered that I have a bunion as a result of a severe battle with the gout, and after taking some NSAIDs, what was left of my foot was the protruding bone. And I'd like to know what kind of treatment can I do that's non-invasive, supportive treatment, types of shoes, or how can you help me with that, please? Thank you.
Hello, Stephen. I unfortunately only heard part of that question.
Okay, well, Stephen was asking, he actually has a bunion, and he was just asking if there was something that he could do that was minimally invasive or just something to do with shoes. But we could also refer him, because you have other people in your practice that might be better suited to answer that question, and
Sure.
you're welcome to refer him.
I can give you a quick answer on that one, Stephen. For the most part, bunions or deformities of the foot, they're very common, and the only indication to have surgery is pain. Most people can get by without having pain if they go without shoes, for example, wear shoes with wider toe box. You can have orthoses which are placed between the toes to help to keep the toes from pushing over further. Even if you do have surgery, you can't go back to wearing tight shoes and that sort of thing. So I would exhaust all avenues of conservative non-surgical treatment before I go there, and only consider surgery if it's a significantly painful situation. Don't do it at all because of the way it looks.
All right, thank you for your call, Stephen. That was great advice. And I think that what we'll do is we're, again, going to open up those phone lines, 361-4675. Again, that number is 361-4675. And today, we are discussing shoulder problems and shoulder injuries. So if you have a shoulder problem or injury, please go ahead and call us. How do you become a specialist in arthroscopy and arthroplasty?
In my particular instance, you go through 4 years of college and then 4 years of medical school, and that gives you the basis for learning about orthopedics. Then you spend 5 years in orthopedic surgery. From there, I did a arthroscopy sports medicine fellowship taking care of the athletes at the University of Iowa. And then I did a shoulder training as well under Dr. Richard Hawkins in Canada. Very unique experience to work in the Canadian system as well. And because of those two subspecialty trainings, I went out into practice and I pursued primarily what I trained in, sports medicine, knee and shoulder problems.
Now, what is the main difference, or what is the big difference between arthroscopy and arthroplasty? I'm not really clear on that.
Sure. So I should mention that to be a sports medicine certified, you also have to take a board exam. I failed to mention that. To become an orthopedic surgeon, you have to take a board exam, and once you're boarded there, you can go on and get a subspecialty exam, and sports medicine has a board as well. That's another way to be subspecialty certified. So arthroscopy really is an outpatient procedure. It's minimally invasive, small incisions, in many instances not painful at all, don't even need a pain pill, depending on what kind of procedure you're doing. And arthroplasty is for an arthritic joint where you put a new surface on the joint. It's a hospital procedure instead.
Now, do you see all sorts of orthopedic problems in your practice, or do you limit your patients to only knees and shoulders? I mean, do you go further than that?
Depends. If I have my, patients over 18 years now, if they have a terrible problem with their back or something, I would, of course, help them out. But if they went on to need surgery, I don't do spine surgery anymore. I don't replant hands anymore, and specialties like that. Nobody does all of orthopedics, and so I just try to pursue just the subspecialty things that I do, mostly knees, shoulders, and hips.
Well, it's probably better if you're seeking somebody rather than just going to somebody that does absolutely everything, to seek a specialist because they have that extra training in those specialties.
That is true. Virtually no one does all of orthopedics, all of orthopedic surgery, because it's just too big. You can't remain state of the art at all things. So it is good to find a specialist in your area.
All right, we have another phone call. We have Kathleen on the line. Hi, Kathleen. Welcome to Local Doctors on Call. What is your question for Dr. John Moor?
Hi. I wanted to ask a question about rotator cuff. And what I wanted to know is, I had been seeing an acupuncturist, and they had, I have a tear in my rotator cuff, and my surgeon had said, eventually that I would need surgery, but the acupuncturist seems to feel that there's something they can do through acupuncture. I wanted to know, have you, in your experience, seen people who really probably should have gone in for surgery sooner and tried to go for, alternative medicine?
Hi, Kathleen. That's a great lead-in to rotator cuffs, because that was a lot of what we're going to talk about tonight. And certainly there are lots of different types of rotator cuff problems, and not all of them need surgery, no question about that. As far as alternative medicine, I think that what we do is so-called standard medicine and complementary medicine, alternative medicine. And we really address all of those things simultaneously. So I'm not opposed to any intervention that works. The key is it has to work. I wouldn't want you to pursue things that have no chance of working. So if you have a rotator cuff so-called tear, it's a little bit of a misnamed entity, because rotator cuff tear sort of connotes that you take an intact seam and you rip it or tear it off, and that's not at all what happens with a rotator cuff so-called tear. In fact, if you have 60-year-old people, take them off the street, no injury, no symptoms, and you get MRIs on everybody, 60% of those people, no injury, no symptoms, will have a rotator cuff tear. In other words, they have a defect there. And it has to do with wearing of the cuff. It's kind of like if I were to walk around on my knees, eventually there would be a hole that would form in the material. And it's not really a tear per se, it's really that the material wore away, it eroded, there's a defect there. And indeed, that's what a rotator cuff defect tear is. And so we know that no one with a full thickness hole in their rotator cuff tendon actually heals it spontaneously. There's no chance of that. We do know that there are people with a rotator cuff problem, even a full thickness hole, who will not have symptoms. Some people, like I said, don't even know that they have a problem, much less no injury. And some of the people who have symptoms can go on and their symptoms can diminish. Maybe they can't paint ceilings anymore and work overhead nonstop with that shoulder, but they can get to a point where they can live their life and accomplish the things that they want to do, daily activities, with a rotator cuff, a hole in a rotator cuff, and still get by. So before you would pursue having a surgery on a rotator cuff, you want to exhaust the non-surgical problems and find a way to help yourself rather than harm yourself. All rehab is not good for rotator cuffs. You can have good rehab, bad rehab. There are good activities, bad activities, good treatments, good bad treatments. So find somebody who knows about rotator cuffs and make sure that they're not just whisking you off to surgery, because that's not necessary in everybody. Rotator cuff surgery does work, but not everybody needs it. I hope that helps a little bit.
Thank you very much.
All right, thank you for your call, Kathleen. We're going to take a break, and when we come back, Dr. Moore will be answering more of your questions on Local Doctors on Call. So stay with us. Welcome back to Local Doctors on Call. I'm Alex Redmond, and today we are being joined by Dr. John Moore. He is an orthopedic surgeon, and we are discussing arthroscopy, arthroplasty, and rotator cuffs. And I believe we have a phone call. Michael, are you on the line?
Yes, I am.
Hi, Michael. Welcome to Local Doctors on Call. What is your question for Dr. Moore?
I'm in my early 60s, and when I was a youngster in my 20s, I had a skiing accident while downhill skiing that popped out my shoulder.
Okay, you had a skiing accident which popped out your shoulder. Is that correct? When you were in your 20s, you said?
Yes.
Okay. And you're in your 60s now? Okay.
I never had any shoulder surgery or repairs,
Okay.
just physical therapy.
Mm-hmm.
But now, years later, it hurts in my right shoulder.
Okay.
So roughly 15, 20 years ago, my doctor back in Seattle started injecting me with cortisone shots. And that's been very helpful for the pain. What does the doctor think about that?
So if you had a dislocation of your shoulder way back when you were about 20, did it come out again, ever?
Never.
Okay, so that's probably not much of an issue anymore. So when you're 20, you're very elastic, you're very pliable. And even though the shoulder dislocates, if you can keep it in until you're 60, that's probably a moot point at this late date. So don't worry too much about instability and dislocation problems. So you're the average 60-year-old person that we just talked about. And so if you're 60 years old, you have a 60% chance of having a rotator cuff tear. And so statistically, you would have a chance of having pinching between your shoulder blade bone right here and your arm bone here. So when you bring up your arm like this, does it hurt you? This sort of motion makes it hurt sometimes?
Yeah.
Yeah, that would be classic. So you likely have some sort of impingement, pinching between the shoulder blade bone and the arm bone, pinching of the rotator cuff, the bursa, the biceps tendon, and that's probably what your Seattle doctor was injecting to make you feel better. The injection does not cure you. It just makes the symptoms abate or diminish so that you can get back to what you're doing again. And periodically the symptoms will come back if you're doing too much, like swimming or overhead activities or hitting tennis balls or who knows what. So I guess I would find somebody that knows about shoulder problems and have them take a look. Injections are okay intermittently. They can help your symptoms and get you back to what you want to do. Sometimes just some rehab, teaching you what not to do and what to do will help. And on rare occasion, it needs to have a surgical intervention as well.
Well, thank you.
You're welcome.
Thank you for your call. What are some of the most common injuries that some of your patients have, say, in the shoulder? What are some of those injuries?
So the most common by far and away in this population is rotator cuffs, and that's predominantly because we have an older population as opposed to the Midwest, for example. Rotator cuff pathology happens just in a continuum of normal to abnormal. It can be a little bit of scuffing and pain. It can move on to partial thickness rotator cuff defects or tears. It can be a full thickness defect or a tear. It can be a small, like a centimeter big, or it can be 5 centimeters. The entire cuff is detached from the top of the arm. So that's by far and away the most common diagnosis in our population. Just like our last caller talked about, instability, dislocations occur, arthritic changes, total shoulder replacements occur, but the great majority are problems of overuse and relatively mild injury. Maybe we see 50 patients a day and we end up doing 15 surgeries a week. So not very many people end up needing surgery for their shoulder problems.
Is it possible for someone to have a very, very small tear and yet have a lot of pain, and vice versa for someone to have a larger tear in their rotator cuff and not be in as much pain?
Indeed, no question. So just because you don't have a rotator cuff tear, so to speak, a full thickness hole, doesn't mean that you don't need intervention. In fact, very small tears, or even not tears, just pinching and scuffing can cause tremendous pain, and that can have intervention to make that go away permanently. Or you can have somebody with a relatively large defect that really don't have any symptoms at all. You don't see many 90-year-olds do this. It's because their rotator cuff doesn't work almost all the time in a 90-year-old, but they've learned to live their life, and not many 90-year-olds need to have rotator cuff surgery either.
Are there certain things that people can do in their lives as they get older, 20s, 30s, 40s, going on, that can help them to strengthen and protect their rotator cuffs?
To some degree, avoiding painful activities and strengthening muscles that support the shoulder will help. But to some degree, it's just a matter of being 60 rather than 20, and some of those things just happen irrespective of our best efforts. So if a person does develop shoulder pain of impingement, then we ask them to avoid pinching positions, and it's very helpful to turn that whole process around. Even a partial thickness cuff tear, so to speak, can heal spontaneously. It's only when it's full thickness that it won't heal. So there are activities to avoid, activities to do, rehab to do, and rehab not to do.
All right, we have another phone call. We have Willie on the line. Hi, Willie.
How you doing?
Good. Welcome to Local Doctors on Call, and you have a question for Dr. Moore.
I'm talking to him on TV. Yes, at night when I can't.
Oh, hi, Willie. Can you turn your television down, please? If you turn your TV volume down, we're going to be able to hear you much better.
Do you hear feedback?
Yeah, you just got to turn the TV volume all the way down.
It's down. It's down.
Okay, go ahead.
Okay, like I tried my right shoulder. I get a lot of pain in my right shoulder. I can't lift it up. I know I have some torn cartilage in it. And I get feel like carpal tunnel syndrome or something in my hand at night and stuff. My grip is real weak, and my shoulder wakes me up at night. And I roll over on it, it wakes me up. It's very sore. What do you think that is?
So, hi Willie. Shoulder pain at night is classic for a couple of different things. Rotator cuff is the #1 problem, so you may have something going on with that, but that would typically cause pain that would be isolated to your shoulder, and sometimes it goes down to the back of your hand here, but rotator cuff problems typically doesn't go to the palm of your hand. So if you're having pain down in your hand on the palm side and the fingers, you may even have a nerve problem emanating from your neck or otherwise. You could have developed some arthritic change over time. So if you have a cartilage problem, as you called it, that's arthritis. or degenerative changes. Arthritis means that the cartilage wears out, so it's bone on bone in there. So sometimes if you're lowering your arm and that sort of thing and it causes grinding and popping, that could be an indication of cartilage wear or arthritis. It's unlikely to have instability, but the most common things would be rotator cuff problem or arthritic change. X-ray and an exam can usually show that pretty readily.
Okay, I think it's my rotator cuff, to be honest with you. I had my left one worked on. I had that one fixed. And the right one is giving me problems now. And it's just very slow. I don't hear any grinding or any popping or anything like that. It's my kids in the background.
Yeah, hi, Willie. I'm going to go ahead and give you some information for you to go ahead and call Dr. Moor's office. Actually, he's going to give you that information because that way you guys can actually have a conversation, and I think that it might be a little bit better, and you'll be able to hear him and he'll be able to hear you. So why don't you go ahead and give Willie your information?
My number is 957-1500. I'm at 2446 South Tamiami Trail. I'm 7 blocks south of Memorial Hospital on the same side of the street. I'm sorry I couldn't hear all of your question, Willie, else I've been happy to answer that. But feel free to call. I'll be happy to talk to you about that on the phone if you wish, or you can come in and be seen as well, whatever you wish.
Great. Thank you, Willie, for your phone call. And I believe we have another caller on the line right now. We have Terry on the line. Hi, Terry. Welcome to Local Doctors on Call.
Hi. Thanks for taking the call.
Yes. Go ahead with your question.
Yes, I'd like to ask Dr. Moore, what is the best way to visualize a tear in the shoulder?
I'm sorry, I'm not hearing the question.
What is the best way to visualize a tear in your shoulder?
Oh.
Now, do you want him to describe what it is?
No, I'd like to know whether a CT scan or an MRI, which would be the best way to determine that there actually is a tear.
CT scans are wonderful studies, but they don't demonstrate the rotator cuff very well. And so if you put contrast in, you can tell that there's a hole there, but you still can't see the detail. So MRI is far and away the better study to look at your rotator cuff. It's still not 100% accurate, unfortunately. Contrast is usually not necessary, but you can put contrast in with an MRI as well. Ultrasound can also demonstrate the size and quality of a rotator cuff problem, and even X-rays show advanced rotator cuff problems fairly well.
Which one would be your preference?
My preference would be MRI without question. You get the most information from that.
With contrast, probably, right?
What was that?
With contrast?
With contrast would make a better study. There's no question. When I was taking care of the Cincinnati Reds, all of our players got MRIs with contrast. There's a little bit of risk in having contrast, though, because it is somewhat toxic to kidneys in some people. So you have to have a kidney test first, or you can do contrast simply with saline or sterile salt water in the shoulder, and that gives you good contrast as well. So either one is possible, and those are easy to organize for you.
Oh, thank you so very much for the information.
You're welcome.
Be checking in with you.
I have to say you answered that so well because a lot of people out there don't even know what contrast imaging is, and maybe you could just break that down, what that is with the dye.
So, so-called dye, which is a word we never use in orthopedics or surgery.
I'm a lay person, I'm allowed.
We call it contrast because it sounds better.
Sure.
But contrast is various things for various entities. So if you're using X-rays, then contrast is iodine-based, and some people can take that, some people can't, depending on whether you're shellfish allergic or not. But for an MRI, contrast is completely different. It's called gadolinium. It has to do with proton density and how much magnetic field and radio waves change given structures. So saline or water also shows up well on MRIs. So the contrast for MRIs is just a way to enhance the amount of tissues that can be visualized, either with gadolinium, the more expensive, more detailed, more toxic one, or just with saline, which is less expensive and maybe a little bit less detailed and no toxicity.
So you do so many rotator cuff surgeries and you treat so many people with rotator cuff injuries. How do you make this easier for your patients and people?
Well, over the years, we've developed a system by which we can do rotator cuffs all arthroscopically, so we never make an incision anymore more than 5 or 10 millimeters. They're all outpatient, so you don't need to go to the hospital. None of them require general anesthesia, so you no longer have to have a tube in your lungs, a ventilator, or a respirator. You have an injection, so your arm goes to sleep, you feel nothing. You can be wide awake during that procedure and talk to me, or you can have sedation. Some people have had a colonoscopy maybe, where intravenous sedation is put in the vein in the arm, and you drift off and you wake up, you hardly even know the procedure's been done. So those are the simplest ways to get things done. Furthermore, after surgery, the block lasts for 12 hours, so you don't have any pain in the immediate post-operative period. We use what's called cryotherapy, which is cold for the shoulder, to diminish the amount of pain pills that you have. The bigger the rotator cuff surgery, the more painful it is. So some people do have pain that require pain pills or narcotics for a few days or even a couple of weeks, maybe if it's a large procedure after surgery. I have had a lady play a round of golf 1 week after her rotator cuff surgery, albeit it was a small rotator cuff problem, not a massive one. But large spectrum of how things can be done. It's much easier on patients than it has been in the past.
So that was going to be my next question, which is when can somebody return to their normal activities? Let's break it down with, if you have a really minor thing, and say golfers, tennis.
So if we have a patient with a rotator cuff problem, but it's just a matter of pinching and fraying, but it's not really big enough, it needs to have stitches and anchors and fixation placed in it, those people on average take 2 months until they can spend an entire day and not think about their shoulder one time. But the sky's the limit, and literally, like I said, a lady can play golf within a week.
All right, well, that's all great advice, and I'm sure that there's a lot of people out there that are going to want to contact you, so go ahead and give out your phone number one more time.
957-1500, course area code 941 here in Sarasota.
And advancedsportsmedicine.com. So we'll see you again next time on Local Doctors on Call, and remember, it's your health. Thanks for watching.